Well, good evening, everybody. I am coming to you from Murfreesboro, Tennessee. I have been here since Monday. Got out of Aberdeen just in time, had about a 20 or 30-minute window to get out before the second heavy band of snow came through. So got out about 6 o'clock on Monday morning, and I'm here till Thursday, which is today. You guys are watching this on Thursday. I'm recording this on Wednesday night, and I'm here till Thursday. And as you're watching this, I'm probably coming in on an airplane, pretty much as you're watching this back into Aberdeen. So the weather's a little nicer here. Not so sure I'm excited to come home to cold weather. It was 65 here yesterday, a little cooler today at 45. Raining like crazy. And tomorrow, I believe it's supposed to be about 60. So going to be just a little bit of a shock when I get off that plane in Aberdeen. It's supposed to be like -20 or so. That should be enjoyable. So anyways, coming to you from Murfreesboro, Tennessee tonight. Going to talk to you a little bit about cardiac emergencies. We had somebody lined up, and then they got busy, and I decided just to do a recording for you guys. We're going to talk about three things tonight. We're going to talk about some scene size up, some responding to these types of emergencies. We're going to do a quick case study, and then I'm going to talk to you a little bit about community risk reduction, which is why I'm here at a community risk reduction symposium. So what better time to talk to you about how we can reduce the risk in your community on the cardiac side of things. So when we're talking cardiac emergencies, they come in all different shapes and sizes, all different times of the day, and they can be pretty minor, and they can also be very severe with everything in between. So obviously our scene safety, we want to make sure that scene is safe for ourselves and our partner. We want to follow our standard precautions. Make sure you're wearing your mask, make sure you're wearing your safety goggles, your gloves, all that stuff that your local protocols tell you that you need to be wearing. We also need to obtain the nature of illness from dispatch, from the scene, from our patient if we can, and then also from family members or bystanders. Sometimes they're going to be the best people to get information from if we can't get it from the patient. So listen to those folks and try to calm them down. It might be a very stressful situation for them, but try to get information as best as you can. Then we're going to go ahead and we're going to form that general impression. That's our first visual contact with our patient. If they're unresponsive and they're not breathing, begin CPR, get your AED, get your heart monitor, get your LifePak 15, whatever you guys have, get that ready to go, and get the patches on the patient and do CPR, get your Lucas device out, all of that good stuff. If our patient is conscious and breathing, we're going to go back to the airway side of things. We're going to check our oxygen saturation. If we're less than 95%, we're going to go ahead and maybe start with a nasal cannula at 3 to 4 liters. If the patient oxygen saturation isn't not coming up, then we're going to go to our non-rebreather at 15 liters. If our breathing if they don't have any breathing or it's not adequate breathing, 100% oxygen with the bag mask device. If they're in the pulmonary edema side of things, bag mask device or CPAP if your local protocols allow for that. We're going to go ahead and check the circulation, check our pulse, check our skin, check our cap refill in these patients. Consider treatment for the cardiogenic shock, which we talked about in the BLS side of things, would be get oxygen on these patients. Then we're going to need to make our transport decision. Depending on how far away you are from the nearest facility, you may need to think about calling for an ALS intercept. We're probably not going to sit around and play very long with these patients, especially if we're 20, 30, 40 minutes away from the hospital, or if they are showing some of those signs of cardiogenic shock. We're going to go ahead and get them loaded up, and we're going to go. We also want to do that transport in a stress relieving manner. We don't want to get ourselves worked up because that will affect how our patient is doing as well. So we want to talk in our calm voices. We also want to make sure that we are treating the patient for what we're seeing and what the vitals are, and not just doing a one-size-fits-all on these patients. Use your vitals, use what your patient is telling you, use how our patient is looking and reacting to the interventions that we've done. We're going to go ahead and investigate the chief complaint. Obviously, if it was chest pain or difficulty breathing, that's what we're going to focus on. Get our sample history, signs and symptoms. Are they allergic to anything? What medications are they on? What's the past pertinent history of our patient? When's the last time they ate something? And then what led up to it, our events leading up. We're going to use our OPQRST as well. When was the onset? What provokes the pain or the difficulty breathing? The quality of that pain. Does it radiate anywhere? What's the severity? And then how long or the time? You can see that outlined here just a little bit more extensive. When did that pain begin? What does our patient think may have caused it? What provokes it? Is it positional? Does a deep breathing or a palpation of the chest make it worse? Does it make it better? Did you take anything? Anything that was prescribed or not prescribed? What do you have on board? What's that quality? Does it feel like there's an elephant sitting on your chest? Does it feel like it's a burning, tearing, dull ache, stabbing? Those are all things that we really need to think about when we have a patient with chest pain. Does it radiate anywhere? Does that pain spread out anywhere? A lot of times you'll have it radiating into the shoulder area potentially, or down the arms. Our severity scale of 0 to 10, where are you at with your pain? Have you taken a nitro? Those are all things that could affect the severity. And then the timing, for how long does the pain last when it's present? Is it continuous? Is it intermittent? Where are we with that pain? If we have time, we're going to go ahead and do our secondary assessment on these patients. We're going to focus on our cardiac and respiratory systems, focusing on circulation, focusing on respirations, getting that second set of vitals, or maybe even the third set of vitals, and comparing them to that first set of vitals. Where are we at? Also use pulse oximetry if it's available to you. Most of you have that available to you, so go ahead and use it. These patients who are experiencing those signs and symptoms of a potential cardiac issue, we're going to go ahead and reassess them every 5 minutes, every 3 to 5 probably. Or if we have a significant change in that patient, we're going to go ahead and reassess at that point in time. If cardiac does occur, we're going to go ahead and perform CPR and get ready to defibrillate our patient immediately. Reassess any interventions that we did. Provide rapid patient transport in a calm manner. So on our emergency care for chest pain or discomfort, let's get that patient in a position of comfort. If we don't suspect any sort of spinal trauma, head trauma, back trauma, things like that, we're going to let them sit in a patient of comfort. If that's sitting straight up, that's sitting straight up. If it's laying flat, the patient's laying flat. However they're comfortable is how we're going to transport them. If oxygen is indicated, go ahead and give that either by nasal cannula or using the non-rebreather mask. Depending on our protocol as well, on your protocol that you have on your ambulance, we may be able to deliver some aspirin, and we also may be able to deliver or assist with some prescribed nitroglycerin. Our aspirin, what that's going to do, it's going to prevent blood clots from forming or getting bigger. It's going to thin out the blood. 81 milligrams chewable tablets. Recommended dose is going to be 2 to 4 tablets, 162 milligrams to 324 milligrams. Chewed up, swallowed. Not swallowed whole. Make sure they're chewing them up. So some of the contraindications for giving aspirin to a patient would be really if they're allergic to it or if they don't have teeth. That's going to be a contraindication because we need it chewed up. We need it to start working now. Nitroglycerin we could have available in the sublingual pill, sublingual spray, or a skin patch. So when we're going through our sample history and our patient tells us that they're on nitro, let's make sure and ask them, are you on a pill, are you on spray, or do you have that patch that's applied to your chest? On our nitro, the mechanism of action relaxes the blood vessel walls, increases blood flow and oxygen supply to the heart, decreases workload of the heart, and dilates the blood vessels. So what our nitroglycerin does, its mechanism of action is going to be relaxing the blood vessel walls, increasing the blood flow and oxygen supply to the heart, decreases the workload of the heart, and dilates the blood vessels. So some of the side effects of it, though, can be that decreased blood pressure and then that severe headache that can come on relatively quick. So some of the contraindications that we have for giving nitroglycerin is going to be, we need to have a systolic blood pressure that's greater than 100. If we have the potential for a head injury, we're not going to give it. And then also if our patient has used erectile dysfunction drugs within 24 hours, we don't want to give it, or we've given the maximum prescribed dose to our patient already. So we need to get a set of vitals before we give or think about giving nitro. Even if they have already taken their first dose of it, we still need to get that set of vitals before we assist them in a second dose. So that's the first thing we're going to do before we give them anything. Our cardiac monitoring side of things, for an ECG to be reliable and useful, electrodes must be placed in the consistent positions. Our basic principles should be followed to minimize artifact in the signal. So our guiding principle, we may need to shave body hair potentially, rub the electrolyte site with an alcohol swab before application, attach our electrodes to the ECG cables before we place them, and then confirm our electrode placement. So as you can see right here, we have our limb leads, which can go on the limbs or they can go on the chest. Smoke over fire, white on the right, and then green is down below that. So we have black over red, white on the right, and then green down below. Our 12-lead ECG placement, you can see right here, we have our V1 through V6, and the different locations and the view that those electrodes are taking. So you can kind of see that on the diagram here. I'm not going to go through them exactly. Should be something you're practicing probably once a month, if not more, so you know where those leads will go. Once the electrodes are in place, we're going to go ahead and switch the monitor on, print a sample rhythm strip. If we have artifact, we're going to go ahead and confirm that our electrodes are firmly applied and the cable is plugged in. And then a lot of times when we're going to be doing a 12-lead or even a 4-lead, we want to make sure that we stop the ambulance if we're able to, because we're going to just have way too much artifact to get a good reading. If you are sending your 12 leads via the Bluetooth side of things to a hospital, go ahead and do that, but make sure that we don't have a lot of artifact. If you don't know what I'm talking about with artifact, look into some training as far as some basic rhythms, so you kind of know what we're talking about and what artifact is. We're not going to get too far into the heart surgeries or cardiac assist devices, but just to let you know, there's a lot of that stuff out there. Abbott Northwestern or Allina Health in Minneapolis did a great presentation for us at our refresher just last Sunday. And you can call them and get some information and maybe even have them do a training for your department if you so wish to, or contact us and we can send you the recording of that talk. So bear with me. I'm going to pause the recording here for a second, so I'll be right back with you. All right, back with you. We're going to run through a case study here real quick. I'm just going to kind of go through these, but as you guys are sitting there thinking about this, go ahead and kind of answer them in your head, or if you're in a group, talk about what some of the questions would be. So you're part of a volunteer, or you are a volunteer firefighter EMT. You live in a rural area, which a lot of us do. You are at your full-time job when your pager is activated. The dispatcher requests your fire department to respond to 403 Reed Road for a 65-year-old man complaining of severe chest pain. The address is 2 blocks from your location, and you respond directly to the scene with your personal jump kit. Remember, if that's what you're going to do, make sure that that's part of your agency's protocol. Advanced life support has been simultaneously dispatched from a location that is about 10 to 15 minutes away. You arrive at the private residence to find an older man in his living room, sitting in a chair and clutching his chest. As you introduce yourself to the patient, he says, "This is the worst pain I've ever had in my life." He tells you that he has had a previous heart attack a couple years ago and that he thinks his nitroglycerin is in his bedroom, but he didn't feel well enough to go get it. A fellow EMT arrives with your fire department's EMS equipment, including an AED. You ask him to look for the patient's nitro while you apply oxygen and take vital signs. So what other signs and symptoms might be found in a patient who's having a heart attack? The list is long. We've got that chest pain. We've got somebody who's very diaphoretic, the impending doom type feeling, that severe pain, sweating, nausea, vomiting, all sorts of them, right? So as an EMT, you can assist the patient with his or her own prescribed nitro. What must you know before administering any medications, and what must you specifically know before assisting a patient with nitro? Obviously, we need to know if it's prescribed to them. Is probably the biggest thing that we need to know before we administer it. What we need to specifically know is, have they taken any? Have they taken any ED drugs? And then also probably the most important thing is we need to make sure that their blood pressure is between that 100 and 120-ish, needs to be greater than 100 before we give it to them, because the last thing we want to do is bottom their blood pressure out. So we're going to go ahead and begin our primary assessment, our history taking, question the patient using the OPQRST mnemonic. Like we talked about, onset provokes, quality radiates, severity and time. You learn that the patient was sitting watching TV when the chest pain began. That's our onset. Nothing makes the chest pain better or worse, including breathing or body position. That's what's provoking it. The patient describes the pain as a heavy and crushing feeling. Pain radiates from the left side of the chest to his left arm and into his jaw. The pain scale is 10 out of 10. The pain started just before he called 911 and has been pretty much constant since then. So we got our OPQRST all done right there. You look for the presence of medication patches or scars indicating previous heart surgeries, or the presence of a cardiac pacemaker defibrillator. None are found. The patient's vital signs are a blood pressure of 160/98, a pulse of 110 beats per minute, and regular respirations at 24 breaths per minute. And his pulse oximetry has a reading of 99. It was 92 originally on room air. What other mnemonic is helpful in obtaining the rest of the information needed that's not addressed through our OPQRST? That would be their sample history. Signs and symptoms, are they allergic to anything? What medications are they on? Their past pertinent history, their last oral intake, and then the events leading up. Your partner enters the room with a bottle of nitroglycerin. It's important to know the rights of medication administration prior to administering any medication, including right medication, right dose, right time, right route, right patient. And you must specifically know that a patient's systolic blood pressure is adequate per our protocols, excuse me, prior to administering nitroglycerin. You must also know the indications, the contraindications, and side effects of our medications you assist with or administer. Your partner examines the nitro, obtains permission from medical control, and then assists the patient with its administration. Now, some of you may have protocols in place that you don't necessarily have to call, but make sure that you know what your local protocols are. What other tactics can you employ to assist this patient? You can just kind of think about those. We're just going to help them take their medication. Make sure we're using a gloved hand if we're talking pills, so we don't get any of the residue on our hands. As we all know, nitro pills are wound very loosely, so they're very powdery. You relay the patient's mental status, age, chief complaint, history of heart attack, vital signs, and your treatment to the incoming ALS unit. Their estimated time of arrival at the hospital is approximately 10 minutes. Because he is not in cardiac arrest, you keep the AED nearby, but do not apply it. Kind of something really good to remember is let's not slap that AED on if our patient is alert, conscious, talking to us. It might just add a little bit of a issue if you slap AED patches on somebody who's awake. You confirm that the patient is not allergic to aspirin, and you dispense 2 81 milligram tablets for 162 milligram total of baby aspirin per our protocols, noting that the medication has not expired. You instruct the patient to chew and swallow them. What can you do to prepare for the paramedics' arrival? Get our vital signs, make sure we have everything documented that we did that we can pass along to the paramedics, give them a report, an update on our patient is probably one of the biggest things. Talk to them, let them know what we're dealing with. You hear the paramedics arrive, you meet them at the door, you give your most recent set of vital signs, explain that a total of 2 nitroglycerin tablets have been administered along with the aspirin, and now his chest pain is down to a 4 out of 10. You help the paramedics place the patient on the stretcher. A 12-lead ECG is performed while the partner prepares an IV in the ambulance. As the machine prints out the ECG findings, you and the paramedic begin to move the patient to the ambulance. He asks you if you would accompany him during transport. Your partner hands the paramedic a grocery bag containing the patient's medicine bottles, which isn't really out of the norm. Pretty much a grocery bag. As soon as the patient is loaded into the ambulance, the paramedic instructs his partner that he is ready to go. En route, you obtain another set of vitals while the paramedic starts the IV. Given that the patient's systolic blood pressure remains greater than 100, how many additional nitroglycerin tablets can you expect the paramedic to administer? I would say 1 more. I believe that is what the normal dose is. It's three nitro doses, and that's where we would stop. We need to call medical control after that. What other forms of the medication may be given instead of the tablet, and what problems can you encounter when examining or using a patient's nitroglycerin in the field? So we can do sublingual spray, or we could have a patch on our patient. And what problems can we encounter? We can encounter that our patient's nitro could be expired. We could also encounter that it's not prescribed to them. So those are all things to remember and things to work through and understand before we get in that situation. Patient now rates his pain as a 3 out of 10 as you obtain another set of vital signs. Paramedic radios the hospital and provides patient updates. You give your blood pressure reading to the paramedic, who during the radio report administers another dose of sublingual nitroglycerin using a meter dose spray. After the report, he asks you to complete a secondary assessment while he transmits 12-lead ECG to the receiving hospital and prepares morphine for administration. Checks the blood pressure again and asks the patient to rate his pain, which he says has not changed. The paramedic then confirms the patient is not allergic to morphine and administers a single dose through the IV line. By the time you get to the hospital, the patient's pain is gone. As an EMT, why is it extremely important to obtain accurate vital signs? Well, we've said it numerous times tonight. We've talked about needing to make sure that our patient has a systolic blood pressure greater than 100. How can an inaccurate blood pressure reading affect patient care, especially during this type of scenario? We could end up bottoming that patient's blood pressure out and then starting to run into all sorts of other issues. So making sure we have that accurate blood pressure is extremely important in this scenario. Our summary, inaccurate blood pressure measurements can significantly affect treatment options and decisions that must be made regarding our patient care. For example, if the nitro is administered because of inadequate blood pressure reading, this could have detrimental effects on the patient or exacerbate his condition. Never estimate the reading. Make sure you know. Ask your partner to help should it become necessary. Scenario demonstrates the impact you have as an EMT in the first few minutes of the call. Your knowledge and actions can make the difference in a patient avoiding permanent disability or death as a result of a life-threatening situation such as a heart attack. Working as a team with ALS and understanding the needs of these providers can also assist in the overall quality of patient care. The transition from BLS providers to ALS providers to an emergency department physician should be seamless and without any interruption or issues. With knowledge and teamwork, all of our levels, even starting down the EMR level, the first responder level, which they are still our most important piece of this because they're laying the foundation for our call. We can all work together and provide the best patient care possible. All right, I'm going to pause this recording for a second, and then I'll be right back with you. All right, back with you again. I'm going to talk a little bit about community risk reduction and what you guys can do in your communities to better prepare your EMTs and your firefighters, your paramedics, whatever you have in your community when there is a cardiac arrest situation. So some of the things that you can do as a department is you can go ahead and sponsor some CPR AED classes for your community. I know a lot of you probably do it already, but if you're not doing it, I would strongly consider that you either send somebody to become an instructor or have an instructor come in and maybe sponsor the event if you can, and get more of your people and citizens in your community trained in CPR. And then also getting an idea of where AEDs are at in your community might help, and might help you as responders, because if you're not working on the ambulance, you may need to know where those AEDs are. We're obviously going to look in fitness centers, daycares, churches, schools, high traffic assembly type areas. So if you don't know how many you have in your town, I would strongly encourage you to take a look around and find out what you actually have in your community. There are some different grants available if your community is lacking in AEDs. You can get a discounted AED through the Avera Heart Hospital. And I know that there's a program through Sanford as well that you can apply for a grant for an AED. The Avera grant is just a discount. I think for $1,000, you can get an AED and a wall cabinet, which is relatively inexpensive. The Sanford program is they will sponsor you as an organization and they will place one for free, but it's a lot more competitive type of a grant. Avera just offers the discounted rate, and everybody who wants one at that discounted rate has to fill out a form stating your organization, kind of why you want it, where you need it, and you're approved if you fit into their parameters. Also, another way to look at the potential for the community risk reduction side of it is getting into your church type groups, going to your churches in your town and saying, hey, would you guys like to have a CPR AED class in your church? If you're able to, try to keep the cost minimal. And if you can sponsor the whole thing, that would be great. Bring in a certified instructor so you're actually getting certification for it is the best way to do it. But also just teaching CPR and AED use is vital if you don't have the means to get a certified instructor to actually do a certified class. Some other things would be just that awareness side of things, teaching people what to look for, teaching people the chain of survival, call early so we can get the emergency response folks activated. If you don't have these programs in your community, like a community CPR training or placement of AEDs, or even knowing how many places in your town have AEDs, I would strongly suggest that you do it. We've talked a lot of things this week, and CPR AED training is one of the biggest things that can really help a community respond to cardiac arrest within their community, within the public, and gets some of the best chances of survival for those patients out there. The more people we have trained, the better chance those folks are going to have. So with that, I'm going to leave you tonight. I don't think I went a whole hour. I know I had to stop and pause because I got a couple of calls. So hopefully it's not too chopped up. I hope you get something out of it. I hope you take something from it. And I get to come back to the Arctic tundra of South Dakota in about 22 hours. So I hope you enjoy it tonight. I hope that everybody stays safe, and we'll see you guys next month.